ഓക്കെ, അത് ഷെയർ ചെയ്യാനുണ്ട്. അത് ഏതെന്ന് ചോദിക്കട്ടെ. ഏതാ ഷെയർ? ആരാ അത് ചെയ്യുന്നത്? ഏത്?
Good morning, everybody. Good afternoon, everybody. Warm welcome to yet another edition of Believer Students Clinic. We are very sorry that it started a little bit late. This, as you all know, Believers Clinics on Thursdays at 3:30 and Saturdays at 10 a.m. is part of the vertical integrated undergraduate virtual classes on Zoom platform. So today, as for the usual classes, we request the students and attending faculty to make this an interactive session by posting questions in the chat box. So students, on your mark, get set, here we go. The first presentation is by the Department of Ophthalmology, followed by Department of Endocrinology in view of the World Diabetes Day, which is on November 14th. World Diabetes Day is a primary global awareness campaign focusing on diabetes mellitus. It is held on 14th November every year, and it is led by the International Diabetes Federation, or IDF, and each World Diabetes Day focuses on a theme which is related to diabetes, and this year it is nurses or the diabetic educator and diabetes. But here we are covering syllabus which is related to diabetes. So as we know, there are two types of diabetes, that is type 2 diabetes and type 1 diabetes. Type 2 diabetes is preventable and it is a treatable non-communicable disease, while type 1 diabetes is mainly managed by insulin injections. And we all know that World Diabetes Day marks the birthday of Frederick Banting, who along with Charles Best and John James Rickett MacLeod won the award for discovering insulin in 1922. So coming to the first academic session, a case of retinopathy by Dr. Rosu George Matthew. Now, this will be followed by a discussion by Dr. Shajik Koshi on retinopathy, and your knowledge in diabetes will be tested by an MCQ at the end by Dr. Philip Finney, consultant endocrinologist, Believers Medical College. Now, let's start coming to the first class, which is a case of diabetic retinopathy. Dr. Rosu George Matthew did her undergraduate course at Pushpagiri Medical College and post-graduation from Pondicherry Institute of Medical Sciences. Over to you, Dr. Rosu George Matthew.
Good afternoon, everyone. I'll be presenting a case. A 56-year-old male who was a diabetic for 12 years came with complaints of decreased vision in the right eye since 3 months. On examination, his vision unaided in the right eye was 5/60, which improved to 6/18 with pinhole, and in the left eye was 6/80 with pinhole. There was no improvement. Anterior segment was found to be normal in both the eyes. Intraocular pressure was 21 in the right eye and 18 millimeters of mercury in the left eye. Fundus examination. This is the fundus picture of the right eye, which shows normal optic disc and vessels. We can see there are dot hemorrhages and blot hemorrhages with microaneurysms in all the 4 quadrants. There are neovascularization in the supratemporal and infratemporal arcades. This is a magnified view of the neovessels. You can make out that they are fine vessels with an arborizing pattern. This is the picture of the same eye with periphery is clearly seen. You can see few cotton wool spots in the periphery, and dot hemorrhages and blot hemorrhages are also seen. Coming to the examination of left eye, optic disc and vessels appears normal. The dot hemorrhages and blot hemorrhages and microaneurysms are seen in all the quadrants. In the supratemporal arcade, there is a neovascularization, and near the fovea, you can see few yellowish lesions which are lipid deposits. They are the hard exudates. Near the fovea, they are suggestive of macular edema. So this is a pan-fundoscopic view of the same eye that shows cotton wool spots here, and here you can see few dot hemorrhages also. This is the OCT macula of both eyes. The warm areas shows increased retinal thickness and that is suggestive of macular edema. Here you can see this is a cross section of the retina that shows all the 10 layers, and macular edema is seen in both eyes. Fundus fluorescein angiography picture of the right eye that shows capillary dropout areas and leaking new vessels. The capillary dropout areas are marked in yellow arrows. These are the dropout areas, and these are the new vessels where the fluorescein has been leaked. So the diagnosis of both eyes is proliferative diabetic retinopathy with clinically significant macular edema, and OCT also showed CSME. About the treatment, pan-retinal photocoagulation with focal laser is advised in both the eyes. And this is the fundus picture of the right eye after the first sitting of pan-retinal photocoagulation. You can see the hypopigmented lesions in the superior quadrant. These are the fresh laser marks. This is the pan-frontoscopic view of the same eye, where you can see the laser marks in the superior quadrant. Similar lasers will be given in 360 degree in all the quadrants in 2 to 3 sittings. After that, there will be in the left eye also there will be a focal laser and PRP given as a treatment. Thank you.
Students, just wait a second. There's some connectivity issues. Anyway, we are just connecting in few seconds. Everybody will be online in YouTube also. Start from the beginning. This yours? Is that yours? This is yours. So, good afternoon once more, everybody. Now we are coming to Dr. Shaji P. Koshi, who will continue with the discussion on retinopathy. As you all know, he has done his undergraduation and post-graduation from CMC Vellore. Sir, please continue Dr. Rosie's case on diabetic retinopathy. Sir. Yes, sir, please continue.
Good evening, everyone. I'll be just continuing on those slides which Dr. Rose has already presented to you. And as you know, that is a 56-year-old male who has been a diabetic for 12 years and who came to us with diminished vision for 3 months. And one thing that I want to point out is that is age and sex very important. Of course, sex, I don't think it is all that important as far as an ophthalmologist is concerned, because both males and females will be having the same type of diabetic retinopathy. But age-wise, yes. If a person is having diabetes right from his childhood, maybe if he is born, you will not be able to see diabetic changes till he attains his puberty. But as a 40-year-old man, if he's a diabetic, by 8 to 10 years' time, you will be able to see some diabetic changes in the eye. So age is quite important. And duration, as I was telling you now, is quite important. But the problem is, it's very unreliable from the history. Like last week we had a patient who told that he is a diabetic only for 2 years, but he had florid diabetic retinopathy in his eye. Most of these people are unaware of the duration of the diabetes because we don't have any proper yearly or 6-monthly evaluation of the sugar values in a medical system. So very often I found that I don't depend much on the history as far as the duration of the diabetes is concerned, unless the person is quite well educated and if he is having a proper follow-up outside. And one more thing that the patient says is that I've been having diminished vision only for the past 3 months. We always tell the people to take a proper history regarding the duration of the illness, but this is also a history which I don't depend much, because we have seen, recently we had a study in a department and we found that 18% of them never realized that they were blind till we examined them. I mean, one eye. So when this patient is saying that his vision loss is there in the right eye for the last 3 months, it should be much more than that. So even the history of duration of the illness or the diminished vision is something which we don't tend to depend much on. This is a slide that Dr. Rose has already showed you, and we know that. But one thing that I have to highlight on this slide is this. Significance of the visual improvement with the pinhole. If the patient is saying that he is having diminished vision, if he can improve it with a pinhole, as you know, I'm sure that most of you would have done your ophthalmology courses by this time, we pass a thin beam of light into the eye, a very thin beam of light, a pinhole size light. And if the patient is able to appreciate it well, even though his vision is quite down, we can certainly rule out certain things as far as the diabetic retinopathy is concerned. We can always rule out the vitreous hemorrhage. If the patient is having vitreous hemorrhage, this pinhole test will be of no use for the patient. And if the patient is having extensive macular edema, we know that pinhole is not going to improve at all. So if the patient is having improvement with the pinhole, we can almost be sure that the patient will improve with glasses. Of course, he will be having some diabetic changes, but the loss of vision that is seen there as 560 may not be totally attributable to the loss of, to the cause, that is diabetes. So I would always suggest, ask the clinician to carry a small pinhole. It's a round thing with a small hole in the center, a black plastic circular slide. It's always better for the physician to carry it with them because most of the diabetes is first seen by the physician or the endocrinologist. So if they can take it from their pocket and show them and ask them to look through it, and if they're saying that they can see better, they don't have to worry much about it. But if the vision is not improving, then we know that something serious is happening in the eye. And the other thing that I want to tell you is about the anterior segment that Dr. Rose was written within normal limits. Apart from retina, we have to see a lot of things in the eye. And this changes is very often seen in the anterior segment also. When you mean anterior segment, I mean only two things. One is the iris and the other one is the lens. If you look at the iris, you can have a lot of changes in the iris. That's why anterior segment examination is quite important because you can. The same principle by which you get neovascularization in the retina, you can have it in the iris also. So if you look at the iris, you will be able to see small new vessels forming. It can be either very near to the pupillary margin or it can be in the periphery, that's near to the ankle, that's towards the root of the iris. So that tells you that not only is slit lamp examination is important, but also you have to stick in a conioscope and see how the angles are. If you see any new vessels in the angle, then the management totally changes. So second thing that we have to look for is the lens status. Most of these people in the old age group will be having some amount of senile changes in the eye, but people are having diabetic, the senile cataract changes can get accelerated. That's the metabolic component also comes into it. So when you say anterior segment, you'll be primarily looking for the iris, that is the new vessels in the iris, and also you'll be looking for lenticular changes. If you read the Western population, you can say that they also add on something like transillumination of the iris. They say transillumination of the iris because the iris pigments are not that thick for them. So once when these iris pigments get liberated off, what is left is only the skeleton. It is something like a concrete ceiling. You know, it's reinforced. You have all those iron thing that's getting crisscross, those iron rods, and to reinforce it, you are putting concrete on. So once the concrete is out, you can see only those iron rods. In the same way, iris having stroma, and on the base of that, using that stroma as a base, you have a lot of melanocytes, which are the ones that is responsible for melanin production. And for this eastern population, you know, these melanocytes are much higher. So you will not be able to see a transillumination through the iris. Then somebody can ask you, so what do you mean by transillumination? How will you examine for it? That is, through the pupil, you pass a narrow beam of light into the retina. And from the retina, this light is reflected back as an orangish light. You might wonder how this light is become orange. It is something like this. You take a green mirror. I shine a white torchlight onto the green mirror, and once when it gets reflected off, it is a green light. In the same way, when you put through the pupil a white beam of light into the retina, when the glow comes back, it becomes red because of the choroidal blood vessels. And if there are any defects on the iris, you can see those streaks of red light that's flowing through the stroma of the iris, which you will not be able to see in an Indian population. But instead of that, the melanins are getting liberated. But instead of seeing a transillumination, if you look carefully, you will be seeing these melanin, these pigments are getting liberated into the anterior chamber, and it comes out through the aqueous and it gets stuck onto the endothelium. And if you look carefully, you can see these pigments are getting stuck onto the endothelium of the cornea, and you call that endothelial dusting. So these are the main things that you have to really look for when you examine the anterior segment. That is the iris neovascularization, whether there are any pigment liberation, which you can see as pigment deposits on the endothelium, and also you can see the lens, which is getting cataractus in a very accelerated fashion. And then comes the IOP. Intraocular pressure. Is intraocular pressure important as far as the diabetic is concerned? Yes, it is important because you have something known as the neovascular glaucoma. I was just telling you, if you look at the angles with a conioscope, you can see the new vessel that is forming and is passing through the iris and is coming over the Schemm's canal towards the Schwann-Bis line. And whenever you have new vessels, and along with that comes some amount of fibrosis. So if those new vessels are going to remain there for a longer time, you have this fibrosis. And whenever you have this fibrosis, you are going to get some contraction of the tissue. And when you had an open ankle, when this tissue gets contracted, the iris is going to get slowly adhered onto the cornea, to the cornea, whereby the angle is getting obliterated. And it's because of this angle closure, the intraocular pressures are going up, and you call that an angle closure glaucoma. Since it's because of some other cause, you call that a secondary angle closure glaucoma. And to be a little more refined, you can say secondary angle closure glaucoma due to neovascularization. And to put it briefly, call it NVG, neovascular glaucoma. These are things that you have to really look for when you examine the anterior segment. And one more thing that you have to take along with the history is that whether the patient is hypertensive or not. Because hypertension can also have these effects in the retina. Second thing is whether the patient is having any nephropathy, because nephropathy will always augment the retinopathic changes. So whenever a patient who is coming to us, we don't go for any extensive examination of like a renal function test. We just check whether the patient is having any proteinuria in the urine. If so, we refer the patient to nephrologist. And third thing that you have to really take a history is about the lipid status of the patient. If the patient is hyperlipidemic, then the chances of them having more exudates, that is more hard exudates in their retinal, along with the retinal changes is quite high. And finally, anemia. As you all know, anemia, if the anemia is quite marked, you can have retinal hemorrhages and stuff like that, which can augment the finding of diabetic retinopathy. So hyperlipidemic state, anemic state, nephropathic state, and hypertension, these four things are to be really ruled out when a diabetes is coming to an ophthalmic examination. Yeah. I'm sure that you already saw this slide that was presented, and the fundus examination of the patient. That is, we have left the anterior segment and we have gone to the posterior segment and we have examined the fundus. Fundus primarily you'll be looking at the macula and also you'll be looking at the retina, that is extramacular area. And on fundus examination of this patient was 56-year-old, we saw a proliferated diabetic retinopathy with CSME in both the eyes. What so you know what a PDR is and you know what a CSME is. So once when you see a CSME, the next thing that you'll be going to will be to examine the macula with an OCT. People might think whether macula examination with an OCT is absolutely essential. In fact, it is essential because a slit lamp examination will give you a good picture if you're using a condensing lens because your view is stereoscopic. But very subtle changes and very extensive changes, if it's uniform, it will be picked up by OCT in a better way. Because whenever you give lasers, you don't depend on your clinical or your slit lamp examination finding, but you'll be depending on your OCT finding. We have done a fundus examination, that is, we have done a dilated fundus examination. It is because a dilatation is always important because during olden times and the olden thoughts was the first sign of a diabetic retinopathy was mainly in the parafoveal area. Now it has been seen that even if your fovea and your macula is normal, you can still have hemorrhages in the periphery of the retina. So a dilated examination is mandatory for all these cases. And second thing is that whenever you have a diabetic lens change, this lens change may not manifest in the central part of the lens. It might manifest in the peripheral part. So to have a good evaluation of the lens and to have a good evaluation of the early changes of diabetic change in the retina, you need to have a dilated examination. And I was telling you about this OCT. The importance of OCT is, see, now you can see a picture of the fundus here. And this is the macula that you see here. And if you look at the macula carefully, it looks almost normal. But it need not be so, because the things that is not very clearly seen in a two-dimensional way, that's in the X and Y axis. You add an Z axis along with that and you'll be able to see it. It is something like you seeing a piece of cake from the top. You are seeing the cake from the top and you are not knowing the thickness of it or whatever it contains, like whether it has any raisins or any nuts or whatever it is having. So to know that, you have to really make a section of it and look at it laterally. So when you do that, see, this is what you see. That is, you are getting an exact section of the retina, and by getting this section, you can always say where the lesion is, in which layer the lesion is, and if there's a clinically significant macular edema, in which areas. You can even have clinically significant macular edema as small pockets, how extensive it is and how diffuse it is. So that's why we don't confine our examination macula only with a stereoscopic examination, but also we need an OCT. See this. This was, can I put it on this section? If you look at this OCT, see, this is a normal OCT, but you look at this one, you can see that it's looking a little spongy. You can have all the fluid space here. So this is the advantage of having an OCT. And also, if you look at it in the end-on view, all these red things are areas that is highly swollen up because of macular edema, and yellow ones are something that's moderate swollen up, and green ones are relatively normal ones. These are things which I have already seen, and Dr. Rose has already explained to you, but I will go into a little bit of pathophysiology regarding dot and dot hemorrhages. So if you look at the retinal capillaries, it is quite unique because you have an endothelial cell in it. You can see all the endothelial cells. It is tightly packed. And whenever you have an endothelial cell or epithelial cells, it should have a membrane on which it has to rest. That's what is known as the basement membrane. So you have endothelial cells here, this is a basement membrane. And as in most of the other arterioles and arteries, you don't have any smooth muscles here. But you should have some amount of support for that, for which we have pericytes. These pericytes are quite unique. It's having like a pseudopods. It is something like an amoeba. It has pseudopods. It will be hugging around all over the small capillaries. And that's the one, that's pericyte, that's the blue one, is the one that really gives the strength for the whole capillaries. And if something happens to these pericytes, then we know the capillaries have become really weak. So in diabetics, it is found that although there are endothelial cell loss, it is also found that the pericytes are also getting less in number, which brings about a thinning of the walls, a wall that is not having enough strength, which can swell up or which can have outpouchings, something like in the sacral aneurysms. And this is where the cell becomes, the wall becomes very thin, and fluids can, and even proteins can permeate through it externally. This is the basis of this dot and blot hemorrhages, because the capillary which was once quite strong has become weak now. The wall has become weak, through which the blood comes out, the protein comes out, the lipid comes out, and you get all these dot and blot hemorrhages and hard exudates. And you've seen that in this picture. And if you look here in the slide that I've shown you here, you can see the dot and blot hemorrhages there. And you might wonder, how come some of the hemorrhages are flame shaped and some of them are round? Usually, whenever the bleeding occurs in deeper layers, it's impossible for this blood to spread down. So it remains there. And that's why it is assuming the shape of a dot and blot hemorrhage. Hard exudates also, it remains there. And since it is hypertonic, it appears yellow in color. You see here, these yellow things, and you can see the small dot and blot hemorrhages there. But you can also have certain type of edema and certain type of flame-shaped hemorrhage there. How can that happen? Because that's also hemorrhage. For this, I can give a very beautiful illustration that you must have heard of all those fabrics where you have a mixture of polyester and cotton. The polyester fiber will be running in one direction, the cotton fiber will be running in another direction. And if you put a drop of ink on it, those ink are not getting uniformly spread out. It's going parallel to the fibers of the polyester. In the same way, when you look at the innermost layer of the retina, what do we have there? We have the retinal nerve fiber layer, which assumes a particular characteristic pattern in such a way that the whole thing is going to get converged onto the disc. So whenever hemorrhage occurs superficially, it also takes the form of that particular pattern towards which the nerve fiber layer is transversing. That's why you get a flame-shaped hemorrhage. Or otherwise, all the flame-shaped hemorrhages that you see in the fundus are superficial. And dot and blot hemorrhages, which are much deeply situated, cannot move here and there. So it confines itself to that small space into which the bleeding has occurred. In the same way, if you look at this soft X-rays are nothing to do with any capillaries or anything, but those are axonal edema. And you see those axons are also going in that particular fashion. Whenever there's an edema, you get that feathery look for the edema. Those are the soft X-rays. There are no well-defined margins for that. So this is the basis of the appearance of this dot blot hemorrhages and hard X-rays. Now coming to NVE, when we say NVE, it's neovascularization elsewhere. See, that's what you see here. This is an enlarged view here. When you have neovascularization on the disc, you call that NVD. And as I've already mentioned, when you have neovascularization of the iris, you call it NVI. So you have NVD, NVE, and NVI, of which I am least worried. All these neovascularizations are quite dangerous, but of the three, I think NVE is something which is a little less problematic. But if you see NVD and NVE, then it really worried about, because the consequence of that is going to be quite bad, and it happens quite fast. Then finally coming to the FFA. See, one more thing that you have to remember is that we were talking about the capillaries getting deep and them assuming a particular fashion, and you are getting new vessel formation, all those things. But also you should remember that you can also have areas of the retina where the capillaries are totally shut down, where you will not be getting any nutrients for the retina. So to really find out the area of capillary shutdown, a fundus flows angiotemporary helps. And all these round things that you see like as small berries are all small aneurysms. And if there are any clot that's found in aneurysms, it won't glow like that. So these are small aneurysms that you see all over the retina, which you will not be able to see with an ordinary ophthalmic examination. So FFA always reveals something more which you cannot normally see through a normal fundoscopic examination. And these things that is leaking out, these are areas where you have new vessels, and new vessels always leaks. It's not as strong as the old vessels. Now coming to some understanding what new vessels. Why should new vessels form at all? Why should new vessels form at all? We know that the retina is highly dependent on oxygen, and it can get oxygen only through the blood vessels. So whenever the retina is going to suffer, whenever this retina is going to get hypoxia, what is happening is that as an effort, as a last effort for it to survive, it will be sending some signals for some new vessel formation. You must have heard of vascular endothelial growth factors. The retina will liberate it, and vascular endothelial growth factor can always give rise to new vessels. But the problem with these new vessels are, it is not as good or as strong or as functioning as the real vessels, because it is always in a haphazard fashion. It comes in places where it's not really required, like in iris. We don't need any new vessels there at all, but it comes there, and it's also very fragile. The problem with these vessels are that at any time it can rupture and can be possible like a vitreous hemorrhage. So what we do then is that we have to reduce the demand of this oxygen for the retina. So once when the retina is no longer requiring any oxygen, then naturally the new vessel formation also will not be there. So how can I do it? I don't have any drugs to put on the eye and stop it. But what I can do is that all the retina that is already suffering with hypoxia, I can make it anoxic. I can make the retina die, or I can always burn the retina off, so that there will be no longer liberation of this vascular endothelial growth factor from those retina. So whenever this VEGF are reduced, then the chances for new vessel formation is also reduced, whereby we can avoid such complications. And that's why we give PRP. That's what you saw in the initial slides which Dr. Rosen showed you. So, these are the PRP scars that you see there, and we are ablating the retina. We don't ablate the retina in one sitting. I usually take 4 sittings to ablate the retina off, each component at the time of each sitting. And finally, I ablate it, and a large area in the center of the macula, I leave like that, because the central part of the vision is very important. Then somebody might ask, if you are ablating the retina off, won't the patient suffer? The patient will suffer up to some extent, because all of us are worried about the central part of the vision. If I have a good central vision, it's more than enough for me to lead a normal life. And I'm not much worried about the peripheral part of the vision. Like, for example, patients who are having glaucoma. Ultimately, most of them, we have seen that ultimately when they end up with pinhole vision, they come to us saying that I cannot see properly. Whereas the disease process has been going on for a long time. That's the peripheral vision were getting constricted years ago, which they were not bothered. That shows that you are quite dependent on your central vision, not in your peripheral vision. So even if I'm ablating off some of the peripheral retina, I'm not worried about the quality of vision of a patient, because he can survive. But the problem here is they can have problem with night vision. They can have night blindness. It is because the central part of the retina, that is area, and the macula is the area where you have maximum number of cones. And cones are responsible for day vision, and cones are also responsible for color vision. And as you move from the macula towards the periphery, the concentration of the cones will come down, and the concentration of rods, the number of rods are going to be more and more and more. And rods is it's concerned with night vision. So whenever I am ablating the peripheral part of the retina, the patient becomes a night blinded person. We always say that vitamin A is the commonest cause for night blindness, but I think that hardly we see any vitamin A deficiency in Kerala. We can say that patients who have had the PRP are the ones who will be experiencing night blindness much more than if at all there are any patients with vitamin A deficiency. So that's the treatment for PRP. And also, we also have a medical treatment for PRP. That is, we have certain chemicals which we inject into the eye so that the liberation of anti-VEGF is suppressed. We call them anti-VEGF. The commonest that we use here are imemizumab and ranibizumab. That's Avastin and Lucentis. These are available in the market. But the problem with this is that they require injections every 4 weeks. You have to poke into the eye. And every 4 weeks, we have to call them back and see whether there are any new vessels forming. Again, you have to poke. One of our retinal surgeons is working with us. He was telling us that he was having a patient for whom he has given 136 pokes, and she's still coming to him for pokes when he was a problem. So this is the problem with the Avastin as far as we are concerned. In our style of living, I think PRP is the drug of choice or the treatment of choice. The other problem with these pokes are that it's quite expensive. The Avastin is nearly 78,000 rupees, and the other one is nearly 24,000 rupees, and hardly any insurance company covers all this. So Avastin is also there as a second choice, but in our scenario, we prefer PRP first. But there are also retinal surgeons who give a combination therapy where they apply both the PRP as well as Avastin. That is as far as the new vessels is concerned, the periphery. The center we know that the center we were talking about the clinically significant macular edema. How do you treat them? You treat them by giving small burns in the region around the fovea, and you should not touch the fovea. And also one more thing that you have to be careful is that it's a C-shaped burn. If you see here, C-shaped burns, it's because you should not disturb the maculopapular bundle that comes in, which is very important for you to maintain your vision, because whatever falls in the fovea is directly transmitted towards the optic nerve. It will be taken to the brain by these bundles. So you have to be doubly sure that whenever you give grid or small burns on the macula, this area is never touched. And if this area is also touched, then the patient is going to go absolutely blind. And the mechanism of action of these burns are quite different from the mechanism of action of those burns that we put peripherally. Here what is happening is that by putting the small burns, it's so small, it's only 100 microns in size. We are stimulating the pigment epithelial layer of the retina, and they have certain pump mechanism by which they will draw off all the edematous fluid from the back of the retina. So by putting these burns, we are stimulating those RPE, and that's the basis of putting burns in macular area, which is quite different from putting the burns in the peripheral area. And finally, it's my last slide, and people might, if somebody is asking you what are the complications of diabetes, the frequent complications that we encounter is one is unstable refraction. That is, the lens that we have, the human lens, is suspended in the eye fluid, and whenever the sugars in the blood goes up and down, this gets reflected in the aqueous nodes. So whenever sugars are high, because of osmotic principles here, convex lens will become less convex because the fluid is going to go out from the lens externally. Whenever the reverse happens, the lens is going to swell up. So this mechanism of your lens getting less convex and more convex is the basis for an unstable refraction. Retinopathy we have spoken about, and ILCS I have already spoken about. And also there are infrequent changes that's happening in the eye as a complication of diabetes. And the first one is neovascular glaucoma. We have talked about it. Second thing, light pits. That's why that we have to take a proper history, which is known as sanity. Palsies, cranial palsies. The commonest one being 6-nerve palsy. You can get frequent styles. You can have accelerated cataracts, and also you can have body sensation impairment. And this is the last line for you to remember these 2 points. I have put in an abbreviation URI. I always say upper respiratory infection. I put it here, and for you to remember that the GLL, PS, AC, there's an abbreviation that I put for you here. God listens, prays silently, and cares. Thank you.
Thank you, sir. That was indeed wonderful. Thank you, Dr. Rosu George Matthew and Dr. Shaziki Koshi. We come to the last session, that is a rapid fire question in cryopathy in diabetes, macro and microvascular diabetes, principles in management of diabetic retinopathy by Dr. Philip Finney, consultant endocrinologist. Once a patient has reached the stage of diabetic retinopathy, obviously much time has lapsed and he has a diabetic history of more than 10 years. The MCQ is going to be on such patients who have a long diabetic history and he has developed complications. Yes. Dr. Philip has done his MBBS and MD from CMC Vellore and did a lot of work in mission hospitals. So once again, we request the students to make this class interactive by answering in the chat box within few seconds. So over to you, Dr. Philip. Chat box.
Good evening, friends. You've heard an extensive discussion about patients who come with diabetic retinopathy, and we've heard the ophthalmology perspective. Many of these patients who come to the eye OPD with diabetic retinopathy will get referred to the medical OPD and the endocrine OPD to try and improve their glycemic control, because in mild to moderate diabetic retinopathy, often no interventions are done except for ensuring tight glycemic control. And that is what they usually get referred to as. It's quite a challenge to keep their sugars under control so they don't get worsening of retinopathy. So I thought there are about 6 or 7 important points we need to think of as physicians when we manage such patients who are referred to us. And I put them in the form of MCQs to promote an interaction in this session. So the first MCQ, maybe you can try and send your responses on the chat box. The first question is, what percentage of patients with type 2 diabetes can be expected to have retinopathy at the time of diagnosis of diabetes? Do any of you want to look at the choices? 10%, 20%, 30%, 75%. At the time of diagnosis, what percentage will have retinopathy? You can just send the answers on the chat box. I think most of you have got it right. The answer is actually B, and the answer is 20%. So it's important to know, I think the carry home message from this particular MCQ is that many of them already have diabetic retinopathy at time of diagnosis. So we must not hesitate to send them to the ophthalmology clinic, or even if all physicians should learn the art of fundoscopy to screen for diabetic retinopathy, because 20% already have retinopathy at the time of diagnosis, similar to the patient who Dr. Shaji referred to, who came with only 2-year history, but he had advanced retinopathy. So we know that in the community, 50% of patients are, only 50% of the people who have diabetes are even recognized and come to healthcare setups. Many of them don't have, are not aware that they have diabetes. So it's a very big problem, and just that their recognition occurred at a certain point. I'll go on to the second question. It's a good answer. Most of you got the answer right. Next one. Yeah, so when will you screen for retinopathy in a patient with type 1 diabetes? Any of you want to answer? A, B, C, or D? A diagnosis within 5 years, within 10 years, or when they start developing nephrotic syndrome? Can I have some answers? Excellent. I think all of you got it right. So within 5 years of diagnosis, you need to screen for retinopathy in a type 1 diabetes. And we know type 1, usually they come with an acute presentation, and it takes at least 5 years for them to develop microvascular complications like retinopathy. That's a good answer. Good. Most of you got it right. Nice. We'll move to the next question. So here we have a case scenario. We have a 32-year-old lady who's missed her period 6 weeks ago, and we have done a pregnancy test and we found that she's positive. Her blood sugars are high. She's come to the gynae clinic and now they have referred her to us for a good sugar control. Do you want to have a fundus examination? And if so, when would you like to do the eye examination? In the first trimester, or immediately when you see her after delivery, or in the second trimester, and why? Maybe you can chat, put in your answers, A, B, C, or D. Let me see what the answers are. A bit of a silence on us on side. There's no harm in trying.
First trimester of pregnancy.
After delivery, one of you felt the GDM doesn't resolve. One of you feels immediately, yes. Anybody else has any other thoughts?
When will you do fundus?
After delivery. So during the pregnancy, it's not important to check the fundus, right? That's what the impression I'm gathering. Two of you feel that way. That's okay. So I think the point I want to convey is that this is one situation. If somebody is a known diabetic and if they have advanced retinopathy, like proliferative retinopathy, during pregnancy, there can be a worsening of the retinopathy due to pregnancy. And so if, for example, if somebody has got very advanced proliferative retinopathy, I may tell the family, if I had the opportunity to have periconception planning, that she must treat her proliferative retinopathy with whatever measures which was mentioned before we go ahead and proceed with pregnancy, because pregnancy is known to worsen the progression of proliferative retinopathy. So she could have vitreous hemorrhage, she could lose her vision during the pregnancy. So I think that's important to keep this in mind. So I think women should be screened pre-pregnancy, ideally if they are known diabetics, like the pre-gestational diabetes. And then as the first opportunity you get during pregnancy, you must screen them. So the answer is immediately. The next point, we move to the next MCQ. So, sorry, I think we have jumped. Okay, so this is a 52-year-old gentleman who's a known diabetic for 10 years. His sugar control is reasonable and, sorry, it's jumping, and his HbA1c is not too bad. He's got 7%. He mentions that the urine seems very bit frothy and his proteinuria, which was checked, showed that he had 4 grams of proteinuria. So that's nephrotic range proteinuria. His fundus examination surprisingly showed no retinopathy. How will you proceed forward? Some of you want to respond to that? Do you want to start him on ACE inhibitors? Do you want to suspect non-diabetes related renal disease? Or you want to continue the current medicine and repeat the urine sample after 3 months? Or you want to start him on an angiotensin receptor blocker and wait for some time? So I have a couple of answers saying we need to give them ACE inhibitors. Any other answers?
Trisha and C.
Almost everybody seems to be going for A. All right. So I think actually my answer is not A. So the answer is B. Why do I say that? One of the things we must remember is whenever you see a patient having advanced retinopathy or retinopathy of any type, you expect there to be a parallel development of diabetic nephropathy and proteinuria. It's like a husband and wife who are living in harmony. If you see that you have retinopathy, you expect them to have nephropathy. But if you see a discordance between the two, then you know there is a problem. It's not the right combination. For example, if you see this patient has got severe proteinuria, nephrotic range proteinuria, but has no retinopathy. That means that this patient's diabetic nephropathy is not due to the diabetes mellitus. It's most probably because of a non-diabetic cause. So for example, amyloidosis or myeloma. There can be other causes why he's got proteinuria or a chronic glomerulonephritis. So whenever you have a situation like this, maybe we'll have to send for a renal biopsy or further investigate them. So whenever you see a discordance between retinopathy and nephropathy, suspect a non-diabetic renal disease. Yes. The next question, which of the following is true regarding the association of diabetes with diabetic retinopathy, diabetic nephropathy and diabetic retinopathy? The duration of diabetes is directly proportional. So more number of years of diabetes, more retinopathy. Duration of diabetes is inversely proportional to diabetic retinopathy. The duration is not at all related to diabetic retinopathy or none of the above. Can I have some answers?
Sir, A. One of them is written C.
Yeah, so almost all of you have got it right. It's A. The duration of diabetes is directly proportional to the diabetic retinopathy. So the severity of it, somebody is 10 years diabetes, another one has got 20 years diabetes, another one is 35 years diabetes. I think the one with the longer duration is more likely to have a greater degree of diabetic retinopathy. Of course, the type of glycemic control, whether it is very poor, also will affect. The poorer the glycemic control, the worse will be the retinopathy. But duration is very important as well. Yep. So we have many drugs which we give, oral hypoglycemic drugs, and there are a lot of new kids on the block which have come recently, last 5 to 10 years. So are any of these drugs, which of the drug should you avoid in a patient who's got diabetic retinopathy? I have choices of metformin, glimepiride, pioglitazone, sitagliptin. Do you want to choose?
No answers.
Anybody? Maybe it's a little difficult one. Is that? Well, the answer is C. The PPAR gamma receptor agonists, the glitazones, are known to make macular edema worse. So anybody who's got advanced diabetic retinopathy with CSME, you would not want to give pioglitazone because there are concerns that it may worsen due to its fluid and salt retention abilities. It can worsen macular edema. So this is one drug you would not want to give in a patient with diabetic retinopathy who's otherwise got normal kidney functions.
Yeah, metformin also you will not give because
But again, sorry, if the kidney function is absolutely fine, then I will give it. But if they have advanced retinopathy, usually they'll have nephropathy.
So will not give. Then I get worsens cardiac failure also, pioglitazone.
Yes, pioglitazone can worsen cardiac failure. But I think in the context of retinopathy, it's important to know it can worsen CSME. We'll come to the last two questions. Just hold on for a second. It's just two more MCQs, I think. Stop share. Yeah. So they come to the last question. Is a 48-year-old gentleman who has diabetes for the last 8 years. He's got very advanced non-proliferative diabetic retinopathy. He's on 2 oral hypoglycemic drugs at nearly about half their usual dosage. A1C is 8.2%. Which of the following is the best treatment in your opinion? Would you like to add as SGLT2 inhibitor like dapagliflozin or empagliflozin? Would you like to add DPP4 inhibitors? Would you like to stop all his drugs and give insulin? Or would you like to add pioglitazone? And I'm telling you that his renal function is okay. His creatinine is 1.2.
They've all written C.
C. Okay, you're all brilliant. The answer is C. Exactly. When somebody has got very advanced retinopathy, you don't want to be playing around with oral hypoglycemic drugs, which is not a very good handle. You may not have a very good handle on their sugar control. So it is prudent to put them on insulin and get their sugars tightly controlled. Otherwise, with poor glycemic control, their microvascular complications are only going to go up by leaps and bounds. So that's right. We would want to put them on insulin once you find anything more than moderate diabetic retinopathy. I think we would definitely consider insulin therapy as a sure way to control the sugars. Yes. And so I just want to conclude by saying that it's very important whenever you see a patient with diabetic retinopathy in the clinic to check their sugar control and ensure it's normal. Dr. Saju, one of our retinal specialists, often tells me there's no point me giving all this retinal photocoagulation, laser, and all these expensive injections if the sugar control is not good. So he's never in a hurry to start this intensive unless the patient takes a commitment to get the sugar down and works with the medical team. So it's always a team effort between ophthalmology teams and the medical teams to ensure we have good glycemic control if you want to have success. Otherwise, you can spend a lot of money with invasive therapies, and if the sugar control is horrible, all this is going to again recur, and it will be a waste of all the time and effort. So I hope you all see diabetes is a disease that affects almost every organ system, and we must be holistic in our care. And seeing the retinopathy should alert you that his kidneys are also getting a bit of a whack. Thank you.
Yes, sir. That was a fantastic presentation. I think if anybody has any doubts, please put in the chat box. You can verbally also ask some questions. So, Shaji sir, would you like to have some concluding messages to the students? I think I would like to thank Dr. Rosso George Matthew, Dr. Shaji Koshi, Dr. Philip Finney for such a fantastic presentation, Dr. Sadish Thomas, the HOD of Ophthalmology Department, and it is indeed World Diabetes Day on Saturday, and that's why we are holding such a nice program for all of you. And we really thank Jayalashmi, Kirti, Drishya, Nikhil, Cinderella, Divya, John Nelson, Adira, Meda, Nancy Elizabeth, all of you. Really, you really answered very fast and very quickly. We're really proud of you students, and very sorry that we couldn't connect to the YouTube very quickly. And okay, eye is a window to systemic disease, just like how Dr. Ambuja ma'am said, skin is a window to systemic disease. What all can we see? We can see connective tissue disease, disorders in the eye. We can see diabetes and make out so many diseases. We can see tuberculosis, choroid tuberculosis. You can see and you can diagnose tuberculosis. Similarly, you can see afflictant. We can see infective endocarditis, rot spots. So eye is a window to systemic disease. Okay, so thank you so much, faculty of ophthalmology, for taking the time to explain so many difficult things, especially photocoagulation, FFA, so many things in such simple manner, especially Shaji Koshi sir and Philip Finney sir for being here despite being busy day to day. So hope all the students have got excellent messages from today's class. So similar academic sessions will continue on all Thursdays and Saturdays, and we want 100% attendance, okay? So meet you all on Saturday at 11 a.m. and next Thursday at 3:30 p.m. with yet another interdepartmental academic session. Wishing you all a wonderful week ahead. Thank you. Bye.